Good day, Jesse. Are you there? Can you hear me, Jesse? Good morning, Jesse. Are you there? Hey, Martin, can you hear me? Hello, Martin.
Yes, hello, John.
Hey, Martin, you got to work for us.
Yes, okay, I'm ready to do that.
Yeah, you're ready to moderate, right?
Yes, sure.
Yeah, well, you got a camera, right?
Yes, I do actually. I should connect it to this laptop here now. But yeah.
Yeah, we can have you moderate. I'll ask you if you want to moderate. If I get one coming up, I'll send you an email. Did
Sure.
you give me your email? Could you send it again, please?
Yeah, I will send it again.
Okay.
Give me a chance here on the chat box.
Yeah, the chat would be good.
Good. Are we? Listen, John, I wasn't going to say too much about this. I mean, there's quite laudable, the efforts of the Gamma Knife people, and actually we might be starting a Gamma Knife center around here, but there's still a lot, like the volume of patients to make such bold statements, is to my taste, that it doesn't have the power, to statistically show all these things. But anyhow, it's an interesting approach to even radiate asymptomatic, very small tumors. So that's what they believe in. So that's what they're doing.
Yeah. Well, it needs education. Okay, I'll be back, Martin.
Yeah.
I'll be back.
Sure.
Put your email, please,
Sure.
in the chat.
Okay, I'll do it. Chat. Where is it?
Jesse, are you there?
Yeah, I got it now. Okay.
Jesse, the interpreter. Are you there, Jesse, the interpreter? Okay, perhaps she stepped away.
So, John, I just put the email address to the chat box. John, did you see my email address?
Welcome, Ben. Hello, Ben.
Hello, John. Hello, John.
Welcome.
Hi.
Yeah, Jesse's here.
Hi.
The interpreter's here.
Yeah.
Hello.
Hello, Jesse.
Yeah.
Thank you.
You're welcome.
Thank you very much.
You're welcome.
Jesse, you have your camera working? We'd like to
Yes,
meet you. We'd like to meet you.
Okay, but please excuse me that maybe
I know
I'm not
it's
convenient
part
to
of the
turn on
job,
the
right?
video. Yeah, sorry. I will try to turn on it the next time.
Okay. It's no big deal.
Thank you.
Yeah, Ben, we're really going to try to get the Chinese people to ask questions, you know, and Jesse, hopefully, Jesse, when Victor finishes, he's probably going to ask you to tell the Chinese audience that ask you the question, not ask Victor, but ask you. Okay, Jesse? And
Yes.
that way they might be less shy. Do you know what I mean, Jesse?
I can relay the questions, like any questions, to the Chinese
you relay
audience.
the questions, and then you relay the answers. They don't answer Victor, they answer to you. Do you know what I mean?
Yeah,
you know what
but
I
the
mean?
thing is we couldn't have the online interaction with the audience, but they can put their questions in the chat so we can see their questions later on.
Yeah, that's a possibility too.
Yeah.
But they may, you know, I think that they may be a little shy and not want to come into the webcast and take over the screen, etc. However, we may solve that if they ask you, give you the question and you relate it to Victor. Do you know what I mean?
Yes, no problem. If any questions are related to me, I can translate that to Victor.
Okay.
Yeah, no problem.
Fine. However, Victor can get the question.
Yeah.
Okay, I'll be back.
Yeah, thank you.
Yeah, thanks, Jesse, for coming.
Yeah, no worries.
Ben? Hello?
Hello.
Hello, Ben. How are you? How are things?
Fine.
Okay. I will be January. I will be going to Guangzhou. So,
Wow.
But that's far away from Shanghai. You're in Shanghai, right?
Yes.
Yes.
Guangzhou.
Yes, Mayo is. And the Shanghai was really all these lockdown stories. Not nice to come there for travel. Ticket is
Actually,
still
now
very expensive.
Yeah.
So once it's better, I will visit. Okay.
You're welcome.
Anytime.
Actually, we have a ACNS Congress in the end of the October in Shanghai, but mostly online.
Oh, in October.
Yes.
Oh, mostly online. Okay.
Yeah.
Okay. I put my email address in the chat box for John. Maybe you can see it. If you want to send me a hello message, then we can communicate.
You have my email, yes?
I'm not sure. Why not you put it in the chat box? So my email is in the chat box.
Okay.
Okay. Thank you.
You're welcome. If you are interested, you can make a presentation in our Congress.
All right. Okay. I'll
Yeah.
I'll send you
And
something.
yes, you can send me a topic.
Okay.
Mm-hmm.
Okay. Sounds good.
Mm-hmm.
But 但是我不会说中文，那样的东西我不。
It's all in English. Yeah.
It's in
No
English.
problem.
Yes, that will be fine.
Yes.
You know.
Okay.
My medical Chinese is not good. 不好。
No problem.
Okay.
Como gobierno, actuamos ante esta realidad. Este Congreso tiene la particularidad de ser el más numeroso en la historia reciente.
Okay, here's Victor, the man of the hour.
Hello.
Hey, Victor.
Hello, Victor.
Hello, dear Binshu. How are you?
Fine, thank you.
Thanks for this kind and honored invitation.
Victor, you know, the last session, now the audience number is more than 2,000.
Wow, all right.
Some
That's
audience
great.
replay your video and watched it
Oh,
after
it's
the live presentation. Yeah.
amazing.
Mhm.
That's great. Victor's coming to China. Jesse, are you there? Jesse, someone asked me to share the screen. It was a Chinese person. I didn't understand their name. Did someone ask me to share the screen?
Well, maybe it's my technique colleagues.
Oh, that he's fine. Yeah, we can share the screen. It's working as far as I know.
Yeah.
Yeah, we can share the screen. Yeah, he can share the screen. Does he want to test it now? Or we got a few minutes.
Yeah, they're still testing it.
Yeah, okay. Okay, good. Yeah, we got a few minutes. Let me know when the test is done, okay?
Okay, no worries.
Recording in progress.
Because this webcast is designed for the Chinese audience.
Thank you.
So we want to cater to them and make it easy. And once again, I'll explain, and Victor understands. The Chinese, we're trying to get the audience to interact with Victor and ask questions or make comments. And we're going to try to have the Chinese questioner ask Jessie, the interpreter, the question, and she's going to relate it to Victor. Okay, Victor, we're going to try that.
Yes, thank you, John.
Well, because, you know, Victor, just think about it. I think if a Chinese neurosurgeon, he doesn't want to take the screen and ask you directly in broken English or whatever. It's better that they ask in their native language to Jessie so that she can ask you. Hopefully it'll work. It doesn't hurt to try.
Thank you, Jesse.
And Victor,
You're welcome, it's my duty.
Que se aprecia en el país. Ha dicho que entre las actividades implementar medidas para el aumento de la producción local y el equilibrio financiero, hacia los cuales también van algunas de estas.
There is too much noise from a
Yeah, I got it. I got it. Yeah, that's my job. Sometimes I slip. Okay, Victor, you ready?
Yes, ready.
Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from the home of Neurosurgical TV, beautiful Miami Beach. We welcome Victor Hugo Perez. Perez, a well-known Mexican anatomist who I've been working with for years, 6 or 7 years online, where Victor is dedicated to teaching neurosurgery to the world. And once you get to know Victor, you'll see it's his passion. He loves it. He loves it. And I also like to welcome Ben and thank him for arranging this, Ben Zhu. Okay, Victor, it's all yours.
Thank you, John. Thank you, Minshu. I feel honored to be with all of you. Today, we are going to talk about anatomy, surgical anatomy of middle and anterior cerebral arteries. Let me go to the whole screen.
Victor, you fell off there, Victor.
I think we are ready. Are we ready?
Yeah, perfect.
Okay, thank you so much. Let's go to the first slide. Okay, anterior cerebral artery. This artery is the smaller of two terminal branches of the internal carotid artery. As you can see in this slide, in this picture, this is the supraclinoid carotid artery, bifurcation, and this is anterior cerebral artery and middle cerebral artery. This anterior cerebral artery arises at the medial end of the sylvian fissure in here, lateral to the optic chiasm and below the anterior perforated substance. It courses anteromedially above the optic nerve or chiasm and below the medial olfactory striae to enter the interhemispheric fissure. near its entrance into the fissure. It is joined to the opposite ACA by the A-A and ascends in front of the lamina terminalis to pass into the longitudinal fissure between the cerebral hemispheres. A1 segment and anterior communicating arteries. The A1 courses above the optic chiasm or nerves to join the anterior communicating artery. The junction of this segment with the right and left A1 is usually above the chiasm, 70% of brains, and rather than above the optic nerves in 30% of those passing above the optic nerves, most journey above the nerve near the chiasma rather than distally. Here we have this beautiful picture in order to see these segments of the anterior and middle cerebral arteries. Here we can see the smaller branches that arise from middle cerebral artery and from anterior cerebral artery. The anterior communicating artery is very important because the microvascular anatomy of this shows great variability in its shape, diameter, and length, presenting fenestrations, duplication, and triplication. The anterior communicating artery has an average length of 6 millimeters with a diameter of 0.8 millimeters to 4 millimeters. An average of 2 millimeters, a single anterior communicating artery is present in 60% of the cases. The A1 is the favorite site on the circle of Willis for hypoplasia. A1 hypoplasia has a high rate of association with aneurysms. It is found with 80% of anterior communicating aneurysms. It is the only anatomic variant that correlates with the location of cerebral hemispheres. This is a variant, anterior communicating variant known as fenestrated. This is found in a low percentage of brains. Here we have like a fenestrations. This could be, this is A1 segment, A2, and this could be interpreted as an azygous artery, but this also can be understood like a fenestrated artery. Let's go to see a video about this anterior communicating artery. Here we have the A2 segments, A1 in the right side, superior suprachiasmal carotid artery, A1 in the left side. This is a very short anterior communicating artery. Here we have A2. We are going also to see a recurrent artery of Hübner coming from A2. So now I want to show you the small branches that are coming from the anterior communicating artery. These arteries are coming from this small segment. Lamina terminalis is open and optic nerves. So in this video, we can see another important variant of anterior communicating artery. Maybe in this video, we cannot see a real anterior communicating artery. Instead, we can see these arteries, these anterior cerebral arteries, joined without a real anterior communicating artery. They are joined side to side, as you can see in here. A1 left side, A1 right side, A2 and A2. Small branches coming from A2 segment. Here I am doing a dissection in order to look the white substance. I dissected the gray substance in this frontal lobe. This is a dissection of gray substance. To look direction of some small branches. A1 segment send branches to the anterior perforated substance. Most of these arteries arise from the proximal half of the A1 segment. As you can see in this picture, this is A1 segment, and in the proximal half of this artery, this artery is sending branches to the anterior perforated substance, as you can see in here. There is another variant of the anterior communicating artery, especially in a large branch coming from it. This is known as a Wilder's Stermic artery that originates from the anterior communicating artery and is found between 1.5% to 10% of the brains. This large artery coming from A1. Let's go on to see another video. Let's go another video. In order to see this very interesting region. This is arachnoid. And these are the optic nerves, left optic nerves. A1 segment, anterior communicating artery. You know, for residents, it's very important to learn how to dissect arachnoid. Once you have dissected arachnoid, you can see much better the arteries. I'm going to separate in here the frontal lobe and cut some arachnoid. And then we can see these beautiful arteries. So here we have the A2 segment of these arteries and these frontal branches. Orbitofrontal branches. And here we have the recurrent artery of Hugo. Recurrent artery of Hugo. Left side and in the right side. Anterior communicating artery, this short segment. Hypoplastic short and long anterior communicating arteries are also observed, as well as the presence of communication between both anterior cerebral arteries due to the union of their respective walls, but without the formation of a true anterior communicating artery, like this brain. So here we don't have a true anterior communicating artery. They are very close, these segments of anterior communicating arteries. We can identify in this picture also posterior communicating artery and fetal variant of anterior of posterior cerebral artery, as you can see in this. This is a fetal variant of posterior communicating artery and hypoplastic P1 coming from basilar artery. Its importance lies in the number of perforating arteries. It originates with a range of 1 to 11 perforating arteries with a diameter between 500 microns and just under 100 microns. Because of their vascular territories that they irrigate, they are divided into 4 regions: lamina terminalis and hypothalamus, anterior commissure, septum pellucidum, paraolfatory gyrus, subcallosal region, and the anterior region of the cingulate gyrus, and genu of the corpus callosum. The number of branches originating from the anterior communicating artery, this is anterior communicating artery in this picture. Here we have supraclinoid carotid artery, the other one, and A1 segments. The dorsal surface of the optic chiasma and the anterior perforated substance. This is anterior perforated substance, right side, left side. These branches have been classified as short and long, the former supplying the lamina terminalis and the preoptic region of the hypothalamus. The subcallosal artery, which corresponds to a long branch, supplies the anterior commissure and the septal area. The recurrent branch of the anterior communicating artery, first described by Hugo in 1874, is unique among arteries in that it doubles back on its parent ACA and passes above the carotid bifurcation and middle cerebral artery into the medial part of the sylvian fissure before entering the anterior perforated substance. It pursues a long, redundant path to the anterior perforated substance. So in this case, I cut the A1 segment in order to see this recurrent artery of Hugo. Here we have the anterior communicating artery, A1 in the left side, and A1 I cut this artery in order to see the origin of this recurrent branch or recurrent artery of Hugo. Look the long trajectory of this artery to enter into the anterior perforated substance. Recurrent branch, or also known as recurrent artery of Hugo. The Hugo or recurrent artery, this recurrent branch is the largest artery arising from the A1 or the proximal 0.5 millimeters of the A2. Here we have A2 left side, A2 right side, anterior communicating artery, and this is the recurrent branch of artery. Very beautiful artery coming from A2 in the majority of cases. It may infrequently be absent on one side or arise as several branches. In our study, there was a single recurrent artery in 28% of hemispheres, 2 in 48%, and 3 or 4 in 24%. If there were 2 or more recurrent arteries, both or at least one arose at the level of the junction of the A1 and A2. Rarely, those more than a single recurrent artery arise from the A1. If there are 2 recurrent arteries and one arises on the A1, the second usually arises at the junction of the A1 and A2. A large basal perforating artery may infrequently arise from the A1 between the A and the recurrent artery. This artery enters anterior perforated substance as a single stem or divided into many branches, average 4. Of the total branches, approximately 40% terminate in the anterior perforated substance medial to the origin of the anterior cerebral artery, and 40% terminate lateral to the anterior cerebral artery origin. The remaining branches pass to the inferior surface of the frontal lobe adjacent to the anterior perforated substance. This picture is also very beautiful. In here, we can see the middle cerebral artery in the left side, anterior cerebral artery, A1 segment in the right side, middle cerebral artery, and posterior communicating artery in the right, in the left side. So, as you can see, in this region, we have the anterior perforated substance. This recurrent artery of Hübner is going to this perforated substance, and with the lenticulo-striates arteries coming from middle cerebral artery. Lenticulo-striates arteries. The distal part of anterior cerebral artery, the distal or post-communicating part of the anterior cerebral artery begins at the ACOM A and extends around the corpus callosum to its termination. The distal ACA is divided into 4 segments, A2 through A5. The A2 infracallosal segment begins at the anterior communicating artery. Here we have the anterior communicating artery. This, and then this is inferior to the callosal cord. The A3 precallosal segment extends around the genu of the corpus callosum and terminates where the artery turns sharply posterior above the genu. Here we have A3. Then A1, anterior communicating artery, A2, A3, this segment that is in front of the genu of the corpus callosum, then A4 and A5. This is another picture from another brain in order to see the branches of the anterior cerebral artery. There are 2 main branches known as pericallosal and calloso-marginal arteries. A4 and A5 segments are located above the corpus callosum. Here is corpus callosum, anterior, posterior, and are separated into an anterior A4 and posterior portion by a point bisected in the lateral view close behind the coronal suture, or with an imaginary line that passes through the foramen of Monroe. This is an imaginary vertical imaginary line that divides A4 from A5. A2 and A3 segments together, and A4 and A5 have been referred to as the ascending and horizontal segments, respectively. The cortical branches. The cortical branches supplies the cortex and adjacent white matter of the medial surface from the frontal pole to the parietal lobe, where they intermingle with branches of the posterior cerebral artery. 8 cortical branches are typically encountered. They are orbitofrontal, frontopolar, internal frontal, paracentral, and the parietal arteries. The internal frontal group is divided into the anterior, middle, and posterior frontal arteries. Anterior, middle, and posterior frontal arteries. And the parietal group is divided into superior and inferior parietal arteries. Anterior canal fossa meningiomas. This is, I'm going to show you in a short time the importance of these anterior cranial fossa meningiomas. They account for approximately 12 to 22% of all intracranial meningiomas. They are classified according to their site of origin into olfactory group, planum sphenoidal, tuberculum cella, diaphragma cella, orbital roof, and clinoidal meningiomas. This is the anterior fossa. Harvey Cushing's illustration showing the large size attained by sertine olfactory group, meningiomas and their relation to the anterior cerebral artery and anterior communicating artery. This is very important to know because when you are resecting these giant meningios, like in this case, we could have a lesion of some branch or indeed the anterior cerebral artery. So we should work with these meningios, with these tumors, with care. So, for example, in this case, look how the brain was displaced by this giant tumor arising from the anterior fossa and invading also the hypothalamus, the suprasellar region. So in this picture, we can see the anterior cerebral artery, pericallosal, calloso-marginal, and the branches, cortical branches from this artery. And here we have some irrigation for the hypothalamus area. I dissect this brain in the hypothalamus area in order to see the branches that are coming mainly from anterior communicating, anterior cerebral artery, A1 segment, and also the posterior communicating artery. These beautiful branches that arise to the hypothalamus area. Foster Kennedy defined at the National Hospital in Queen's Square in London the syndrome in 1911. One syndrome, when present, is diagnostically decisive. A speedy reduction in ipsilateral acuity of vision due to ipsilateral compression neuritis of the optic nerve lying below the frontal lobe, coincident with papilledema and normal vision of the opposite eye. From compression of the olfactory tract, there is usually under these circumstances anosmia in the same side on which retrobulbar neuritis and the primary optic atrophy have occurred. Of this olfactory group and tuberculum cella are the most common sites of origin. Given the benign nature of these tumors, the ideal management is gross total resection with excision of the surrounding dura and bone. Here is the pre-op and post-op in one case. Complete surgical excision of these tumors is a challenging endeavor due to the close proximity to critical neurovascular structures such as internal carotid artery, anterior cerebral artery, anterior communicating artery with perforators, visual apparatus, and pituitary gland. I showed you this video in order to see the variants that I just have commented. Some perforators and recurrent artery of Hübner. Recurrent artery of Hübner. This is a variant. Here we have two recurrent arteries of Hübner, and in this case, only one. Okay, let's go to see this picture. Here we have the giant meningio, and in this case, we have the Wilder artery of Penfield. This is also known as an artery of Penfield, coming from from anterior communicating artery. According to the site of attachment, the most common meningiomas of the anterior cranial fossa are classified into olfactory group, planum sphenoidal, and tuberculum sella meningiomas. Optic nerves, the left, the right, anterior clinoid process, and supraclinoid carotid artery with respective arteries. Anterior cerebral artery and middle cerebral artery. So in this case, I operated this giant tumor. And this is very important to know because these tumors are irrigated by some ethmoidal branches, the anterior and posterior ethmoidal branches of the ophthalmic artery, of which the anterior is the larger, arise beneath the superior oblique muscles and pass through the anterior and posterior ethmoidal canal to reach the dura beside the cribriform plate. Here we have the cribriform plate and the canals where the recurrent artery enters to the skull. Here is cribriform plate. Look, this is another picture in a, this is a picture in a cadaver. Look, the anterior fossa, cribriform plate, optic nerves, planum sphenoidal. As the anterior ethmoidal artery passes across the floor of the anterior cranial fossa near the cribriform plate, it gives rise to the anterior falx artery, which runs between and supplies the anterior portion of the falx and walls of the superior sagittal sinus. The anterior and posterior ethmoidal arteries then pass through the cribriform plate area to supply the ethmoidal sinuses, the infundibulum of the frontal sinus, the anterior nasal cavity, and the skin over the cartilaginous part of the nose. Here we have a dissection of the anterior fossa, and in here we have the orbit. In some surgeries, we need a flap of periosteum to cover the bone and to avoid fistulas. Here is a large flap of periosteum. In this other video, I show you dissection of supraorbital nerve. It's a branch of the trigeminal nerve. We are liberating this branch with a small chisel. Here we have the supraorbital nerve. And then we have an osteotomy, fronto-orbito-ethmoidal osteotomy, in order to gain access to these giant tumors, especially for the base of these giant tumors. Once we have this osteotomy, we could identify the anterior ethmoidal arteries going to this part of the medial part of the orbit. And we can also to coagulate this anterior ethmoidal artery, and this is much better to work with the tumor. The anterior ethmoidal artery crosses near the anterior edge of the cribriform plate. This is the anterior ethmoidal artery. The posterior ethmoidal artery crosses near the posterior edge of the cribriform plate, a few millimeters anterior to the orbital end of the optic canal. Optic nerve, the ocular globe. Arteries that supply the margins of the superior orbital fissure and may be recruited to supply tumors in the region include the anterior branch of the middle meningeal artery, the recurrent meningeal branches of the ophthalmic and lacrimal arteries, the meningeal branches of the internal carotid artery, the tentorial branch of the meningohypophyseal trunk, the anterior branch of the inferolateral trunk, and the terminal branches of the internal maxillary arteries. Here we have the patient some days after the surgery, and here we have the resection of this giant meningio in the anterior fossa. At the beginning of the dissection of these tumors, we can use scissors, big scissors, but when we advance to the posterior part of the region, we should use microscope and micro instruments for resecting this kind of tumors. I am separating the tumor to the brain in order to avoid damage. So here we have this tumor, and look in this MRI imaging. Here we have a very important edema in the brain. So this edema around this meningio could we could have a prefrontal lobe syndrome. This occurs in association with tumors, trauma, or degenerative disease in the prefrontal and orbitofrontal cortices. It's characterized by a conglomerate of signs and symptoms that include impairments in decision-making, ability to plan, social judgment, conduct, modulation of affect, and of emotional response and creativity. Like in this case, I operated also this patient, and after the surgery, we had a edema in this brain, and we had a prefrontal lobe syndrome. Such patients lose spontaneity in motors as well as mental activities, and do not appear to realize that they are neglecting themselves and their responsibilities at home and work. They manifest loss of inhibition in social behavior and are usually euphoric and unconcerned. So let's go to see in some minutes the middle cerebral artery. This arises as the larger of the two terminal branches of the internal carotid artery. The diameter of the middle cerebral artery as its origin is 4 millimeters, almost 4 millimeters at the beginning, approximately twice that of the anterior cerebral artery. Its origin is at the medial end of the sylvian fissure, lateral to the optic chiasm, below the perforated substance, anterior and posterior to the division of the olfactory tract into the medial and lateral olfactory stria. The middle cerebral artery is divided into 4 segments: sphenoidal, insular, opercular, and cortical. Sphenoidal segment. M1 begins at the origin of the middle cerebral artery and extends laterally into the depths of the sylvian fissure. It courses laterally approximately parallel to the 2 and approximately 1 centimeters posterior to the sphenoid crest in the sphenoid compartment of the sylvian fissure. This is a view in which we can see the cortical surface of the lateral aspect of the brain. So let's go to see the sphenoidal segment. I remove the frontal lobe in order to see this middle cerebral artery. Here we have an hypoplastic posterior communicating artery, supraclinoid carotid artery, and bifurcation, and some small branches coming from A1 and middle cerebral artery. These are lenticulo-striates arteries that are going to the lenticular nuclei. Here is the bifurcation of middle cerebral artery. We can see in here the insular segment, M2 segment. I retract this middle cerebral artery, and we can see very nice this bifurcation and an early branch of this middle cerebral artery. M1 is from bifurcation of supraclinoid carotid artery to the side in which this artery is doing an angle of 90 degrees to go to the insular segment. So in this video, I am dissecting the lenticular nuclei. This is internal capsule. This is internal capsule. And I am dissecting the basal ganglia in order to see these lenticulo-striates arteries. I am dissecting putamen, and then we can see the globus pallidus. And lenticulo-striates arteries going to this basal ganglia. Once we have advanced in this dissection, we can see the internal capsule. Anterior, genu, and posterior internal capsule. The insular segment, M2 segment, includes the trunks that rest on the feed the insula. This segment begins at the genu, where the middle cerebral artery trunk passes over the insula of the line and ends at the circular groove of the insula. The greatest branching of the middle cerebral artery occurs distal to the knee when these trunks cross the anterior part of the insula. The branches that pass to the anterior cortical areas have a shorter path through the insula than those that reach the posterior cortical areas. Opercular segment. It begins behind the transverse temporal gyri of the insula and ends on the surface of the sylvian fissure. Its branches join the frontal, temporal, and parietal operculum. Here we have a dissection. I cut the operculum, frontal, parietal, and temporal. The first gyrus of the temporal bone was resected in order to see this segment of the middle cerebral artery. Cortical branches. And here we can see the insular segment when this middle cerebral artery and its branches are close to the insula, and then when this artery is going through the cortical to emerge in the cortical surface is known as opercular segment. Then we have insular and opercular segment. Here we have the big branches or division of middle cerebral artery, frontoparietal and temporal. Cortical segment begins on the surface of the Sylvian fissure and extends onto the lateral cortical surface of the frontal, parietal, occipital, and temporal lobes of the cerebral hemisphere. So here we have an injection of this middle cerebral artery. The great Professor Roton classified these cortical branches into 12 segments, going from frontopolar segment, the frontal, parietal, and temporal. And each one has several segments. I injected this brain with silicone. This is very nice, very good, because we can go through very, very small branches, as in this case. I continue the injection, look at here, I continue the injection, and we can go through a very, very small arteries. This is the advantage in doing this kind of injection, especially in these brains. So the cortical area supplied by the MCA is divided into 12 areas. Orbitofrontal area, in this case, prefrontal zone, precentral area, central zone, anterior parietal area, posterior parietal area. Here we have an scheme to look the irrigation of this middle cerebral artery. Then we have also the angular area to the angular gyri, temporo-occipital zone, posterior temporal area, middle temporal area, anterior temporal area, and temporal polar zone. Then I think this is the last slide, and thank you very much for this great opportunity to give this lecture.
Let's see, the
Thank you so
screen
much.
is still, okay, let me get you up the screen. Yeah, I was surprised when I heard that the Chinese audience was very interested in your webcast because of your illustrations. And we really want to get the Chinese audience to ask questions or make comments. So what we're going to do is have the Chinese audience, if they can, to ask the interpreter. Okay, her name is Jessie. You just ask her the questions directly, and Jessie will be, Jessie, you're there, right?
Yes, I'm here.
Victor,
Yeah, she's there, and she's going to instruct the Chinese audience to ask her the questions, and she's going to relay them to us. That'll avoid you being on camera or being the center of attention. So we're going to give that a shot, and Jessie will field questions now while we continue. Okay, Jessie?
Hi, John. Yeah, I understand, but the thing is, we couldn't like have the real-time interaction with the Chinese audience.
Okay, so what can we do, Jessie?
Um,
What should we do?
If they put their questions in the chat, we can see, you can see their questions later on, and maybe we can tell Victor what questions they have raised, not like the next time.
Oh, okay, into our chat, you mean the Zoom chat?
In our live stream page chat.
Oh, okay, we'll try that.
Yeah.
Okay, and while we're waiting, hopefully to get some of that feedback, we'll open for any questions from the audience here in the panel.
hi, Victor. Thank you for your nice presentation. And yeah, you mentioned that around the ACAM artery, there's some laminar terminalis and hypothalamus branches. Yeah, but actually, it's the importance for this kind of small branch is totally different, because if the branch only goes to the laminar terminalis, it can be maybe sacrificed directly and cause nothing. But if the small branch goes to the hypothalamus, it can be disastrous. So how to divide it in the live surgery? Do you some your own experience that can be introduced to our audience?
Okay, thank you, Binshu. I went to Germany about 20 years ago. In that time, I wrote a small book, the Atlas of Anatomy of Arteries of the Brain, and I listened to a conferences, to a professor that divides the anterior communicating artery in order to gain access to suprasellar tumors. And I asked him the same question that you told me. There is one artery, I think the most important artery in this region is the anterior hypothalamic artery.
Yes.
This artery is not in the 1% of brains, but could be 20–30% of brains that have this anterior hypothalamic artery. If you divide this anterior communicating and cut this artery, you are going to have an infarct in the hypothalamic anterior nuclei of the hypothalamus. And these nuclei have the function of the balance of thermic temperature, in the cord. So the patient, I have seen one case in which it could be damaged, this artery, because the patient, once the patient was awake, he had an imbalance of corporal temperature. The other branches that are going to the optic nerve, to the septal area, maybe are not as important because this is a zone with too much branches, but the anterior hypothalamic artery is only one. And if you are going to divide this anterior communicating artery, you should know that it is large, short, and the number of branches that are arising from this segment. Thank you for the question, dear Binshu.
Okay, actually, in our clinical work, sometimes you already divided the MCA distal part as a different segment, but normally in the clinical work, sometimes if we have some, we clip some artery of the distal part of like M4, there's some collateral blood flow can reflux to the vessel, so it couldn't. Normally it didn't cause infarction, but for the ACA branch, actually I think the collateral was not so good. What's your opinion and your experience for this kind of difference?
Well, I have not done anastomosis of M4 segment, so I don't have experience in this kind of job of surgical approach. So I don't have an answer about the infarct implications doing that kind of surgery.
Victor, you presented a case that is it your routine to remove the anterior cranial fossa meningiomas like you presented in the presentation, that you remove all the bone work, bone fractures, and the anterior the bone and all the base of the meningiomas. And do you do some reconstruct for the anterior cranial fossa?
The reconstruction of we use we could use nylon, nylon, gross nylon, and to do some small holes in the lateral bone, in the, for example, in the frontoethmoidal osteotomy, and then after to join the osteotomies. So the large flap of a periosteum is going through that osteotomy in order to avoid fistulas. So we have not had fistulas doing that kind of surgeries. I know that today there are another techniques like endoscopic reduction of tumor, but I think for giant meningios is still a good option, the open surgery.
Thank you.
Thank you.
Takashi.
Hey,
Takashi.
good evening.
Hi, nice to meet you. Hi.
Nice
Good
to meet
morning,
you. Good evening.
Takashi.
Good evening. Now,
Good evening.
10 p.m. Now, thank you, Victor. Good presentation. Every time I see the microneuroanatomy, so I review again and again. And the very microsurgical anatomy is very important to review. So every time I get a very informative lecture. I appreciate it. Thank you.
Thank you very much, Takashi-kon. Thank you, dear friend.
Professor Ahmed Fawad Prasad.
Yes, he's from
Nice to meet you.
Afghanistan.
Hi. You from Afghanistan. Nice to meet you. Hi.
Salam. Thank you for you. Thank you, Professor John and Professor Victor Hugo Perez. Very nice presentation. It's good illustrated and good case presentation. It was really good for learning purpose as well. And you presented, I heard about the Foster Kennedy and I saw the pictures as well. Thank you. Thank you very much. Arigato gozaimasu.
Yeah, thank you very much. I'd like to introduce another Mexican neuroanatomist, Noe Cerrillo. Noe, you there? Can you please introduce yourself to the audience?
Hello. Un saludo en español primero al Dr. Victor Perez. Hello, I'm going to speak in English now for all the audience. It's a really good pleasure to be here and to listen to Mr. Victor. I really admire his job in Mexico City about neuroanatomy and all the dissections they made. Also, I want to say hello to Dr. Takashi Takane. It's a real pleasure to be with him today. Well, as everybody has said today, the beautiful images that Dr. Victor Perez presented to us today is really nice to identify the vascular anatomy of the circular artery of Willis and identify especially the variants of these kind of branches of the Huebner recurrent artery. In that case, I have a question for Mr. Victor. What are the importance to identify the origin of the Huebner recurrent artery to cleave aneurysm for the anterior circulations?
Well, it's not difficult to find the recurrent artery of Huebner. Most of the times, this artery arises in the post-communicating segment, sometimes in the communicating segment, and a few times in the posterior, in the before the communicating artery. So if you damage this lesion, you could have an infarct of basal ganglia, especially the caudate nuclei. So if you have this kind of lesion, you could have a motor affection in the motor system of the patient. Thank you for your question.
Thank you very much, Dr. Victor Hugo Perez. It's really admirable your job at this section. I know every Mexican in Neurosurgery know your job, and it's really amazing to see your pictures in every Congress. Also, I want to congratulate John, Dr. Takashi Jun, Binju for so much amazing webinar today.
Thank you for coming, Noe.
Thank you. Gracias.
Okay, any comments, questions from the audience? Any questions?
I want to ask.
Hey, Martin, how you doing? Martin,
Yeah,
can you
I'm
introduce
fine.
yourself, please?
Yes, I am a consultant neurosurgeon here and director of a training program, which is maybe not going to continue, but anyhow, I am Swiss and I was in Professor Yazagil's time at his clinic, and I worked in Toronto and in New Zealand. And I do actually speak Chinese, that's how. So,
Okay.
yeah, but now here's my question. And I do also speak Spanish, so
Oh boy.
my question to Dr. Perez is, a long time ago, we used to have a meeting in Tasmania, and we invited Professor Sami over. And conventionally, when you do anterior fossa meningiomas, nobody really, often the patient is anosmic or maybe partially anosmic, and nobody really attempted to save the olfactory nerve. But Professor Sami did, and And apparently he had some success with it. And later on, I also tried this. Usually I could preserve one rather than two. So what is your experience in that regard, Dr. Perez?
In GN meningiomas, I think it's very difficult to respect both olfactory nerves because they are very, very thin. So when you are dissecting in the base of the meningio, most of the times that nerves are damaged by the tumor and not for surgery. And as you have done, I think if you try to respect one of these nerves, you are going to respect the olfactory function. So in our cases, in a big tumors, we have had a damage of the olfactory function.
Okay,
Victor,
thank you.
so you mentioned the esmoid arteries. Actually, it's very important in moyamoya disease, this kind of arteries, because normally it can form the spontaneous stoma with the inferior part of the frontal lobe. So this is a very important collateral route to the frontal cortex.
Mm-hmm.
And actually, I do the revascularization for ECIC. So I use a lot of the ECA branch to revascularize the cortex. So I'm quite familiar to the ECA branch, but I think very few neurosurgeons are very familiar to the ECA branch like the ICA branches.
Mm.
So maybe if you have the opportunity, please present your knowledge about the ECA branches. And according to my knowledge now, it's very important for the like noisy mucosa blood supply from the esmoid or some maxillary arteries branches. Yeah, it's more and more important.
Yes, agree, yeah. Dr. Binshu. A pleasure.
Okay, very good. Okay, Ben, did you mention the numbers of people watching on Medtion?
Oh, let me check. Hi, Mohammed. Hear me? Are you there?
I just checked, Ben.
Yes,
I just checked.
Hi.
There he is.
Thank you.
Please turn on your camera. And do we have some comment and questions?
Yes, I would like to.
Victor?
Yeah, I would like to thank Professor Victor for giving this presentation. I have learned a lot. Thank you so much.
Thank you, Mohammed.
So tonight's audience number is 722.
Very good.
Yeah.
Very good, Victor.
And I think it would be even increase after this presentation because they can check the video. Yeah.
Yeah, I'm going to put it up on the screen there, Ben. Let me screen share the actual simultaneous presentation on medtion.com, which to me is, I think it's the best website for neurosurgery on the internet.
Yeah.
And it has here, Victor, you see it, 2527 watching now. So that's a good audience. So I hope that shows the demand. And of course, certainly, if the medical students of China or the residents of China have a demand for it, I think Victor and I will talk about doing another series in the future. Okay, very good. Okay, Victor, what is the next? Does anybody have any closing comments or questions they'd like to add? If not, okay, I guess we'll close it. Thank you, Victor. What is the topic next week, Victor?
I'm going to talk about arterial circle of Willis.
Okay.
Anterior
Okay.
circle of Willis.
A very important topic. Okay, I'd like to thank everyone for coming, especially Victor and Ben and Martin and Noe and all the people that participated. And we'll see you next week.
Okay.
Good day.
Bye bye. Thank you. Thank
Okay,
you.
bye bye.
Bye bye.